just raise a hand in the chat. So this talk is called Echo for the Non-Cardiologist Beyond the LVEF. So my POCUS Echo credentials, you're wondering, why is Josh teaching us about Echo? I did a lot of POCUS training in residency, and I'm at, like, my generation is the one where none of our mentors knew how to do this stuff, and like we all started doing it and then had to start teaching other people. So I kind of was in that mix where we were implementing all the ultrasound courses and whatnot. I actually ended up teaching one of the courses in PGY3. I actually got to do one of my rotations in fellowship was a whole block of echo, which sometimes was super boring, just sitting in the room doing outpatient echoes while 85-year-olds in the dark farted because they're so relaxed. So that was interesting. I got to do a Canadian resuscitative ultrasound course, which is okay. The SCCM critical care echo course, I would really recommend for anybody wanting to like go next level. It's fairly expensive, but I use CME to cover that. And that's kind of key if you want to do there's like a critical care echo board, which you need to do an exam and have like 250 cases that are reviewed. I never really felt it was worth doing that. It doesn't really change my day-to-day. And then I got privilege for emergent TE here. All that to say, I mean, you know, obviously Dana did a formal cardiology fellowship. We're not talking about, you know, being able to measure and quantify valve lesions. This is all the ICU level stuff, right? Patient has shock, patient has just shortness of breath. We're at like a rapid response or code, and being able to, you know, identify things. I've also found, like, because we get to see the patient, there's been a lot of times where we go back and look at the echo and there's, you know, there's something else going on that was not reported, right? So just having a comfort with that is, I think, a next level skill to have as an intensivist. Trust but verify. Exactly. I mean, same with CT, right? We get to see the patient. The guy on the other end is reading, what, 40 echoes a day sometimes, like, so it just gives us that extra skill. So the objectives here to talk about basic ultrasound and echo physics, kind of the basic transthoracic echo views, common and uncommon shock findings, some basic valve disease, limitations on transthoracic echo, and bonus on Impella positioning. So how do I get this to go full screen? Anyway, so ultrasound's super interesting. There's like these crystals. They're called piezoelectric crystals that are placed on the top of the probe, and when electricity is applied to them, they generate ultrasonic wave, which is ultra meaning above the frequency of sound, so 1 to 20 megahertz. And the interesting thing is those crystals also will absorb the reflective wave and then generate electricity, and that's what generates the it transduces the wave back into electric signal, which then gets transformed into like a picture. So ultrasound waves, there's multiple different things they can do when they leave the probe. They can either be absorbed, so that's going to be things like bone, right? Bone is really going to absorb, and that's why if you see on the ultrasound, you'll see just black underneath, because all the ultrasound has been just sucked up into that bone. Reflection usually will occur in a medium that's conducting ultrasound well, but then there's a sudden change in the density. So for example, if you have fluid and then it hits the diaphragm, you'll get a solid line at that point. So there's good reflection there. Scattering, the lungs and air really scatters. It doesn't transduce ultrasound. So when we look at lung ultrasound, which we're not going to talk about now, but what we're actually just seeing are artifacts. You're not seeing, that's not lung, that's just scattering artifacts from the ultrasound hitting the pleura, and then it enters into the air and just scatters all over the place. So we're just seeing pleural reflections. And then conducted would be like water density conducts great, which is why it's black, because it's not, or hypoechoic would be the term, because it's not, there's nothing reflecting off of it. So the echoes are referring to the reflections of sound back to the probe. And so echo plus cardiography is where the term comes from. Again, water density generally will be no reflection, will be black. Bone, diaphragm, fascia will give you reflection, and that equals signal coming back to the probe, which is why you'll see white, which is we call hyperechoic. The other general principle with ultrasound is a higher frequency gives you higher resolution, but less penetration. That's why like in the ER ultrasounds, you'll have 3 probes, right? You'll have a linear one, which we use for art lines and, veins, because you're getting excellent spatial resolution, but it won't go deep. On the other end, abdominal, you can see 25, 30 centimeters, but it's much less resolution. And if you notice too, as you move the probe, it's like a slower refresh rate, essentially, is a better term for it. But it has to do with the ultrasound has to go much deeper, the wave, and then come back. So you're getting less cycles per second. I think pulse repetition frequency or something is the term. So bottom line is you trade frequency and resolution for penetration. So cardiac echo is kind of in the middle of those, the abdominal and the vascular probe. Very briefly on how Doppler works. So Doppler is the effect what happens to waves when they encounter something that's moving either away or towards them. And the simple way to think about it is, if blood is just sitting here and not moving and a wave gets sent out, it's going to go out at the same frequency and wavelength and come back at the same frequency and wavelength. If something is moving towards the probe, the waveform will come, or the frequency will come back faster. It's almost like compressed, and vice versa. So the machine will kind of calculate this, and you'll, for example, when we see color, it's calculating a velocity, and then it will, it can track color using algorithms. So the one key thing to notice, just to take away from this, is that, well, 2 things. When we see red or blue on the ultrasound, it's nothing to do with our artery or vein. It has to do with, is it coming or going from the probe? That's why if you flip the probe, you'll get the opposite. And then the other key piece is, this is the most accurate when it's in line with the probe, right? As soon as you go offline, say you're sampling this wave from up here, your accuracy of what the velocity is starts going down. And it's, if you remember back in trigonometry, it's going to be cosine, right, of that angle, right? So to the point that if you interrogate this wave from like the top, cosine of 90 is 0. So this is how you underestimate, oh gosh, card call. Okay.
T4?
Call us if you need us, or one of us want to go. Do you want to go? Okay, I'll just keep doing this for academic purposes. So briefly with echocardiography, there's a couple, and I'm not going to go into a ton of this. I personally don't know it to extreme lengths, but continuous wave Doppler will be sending the Doppler signal again, like it sounds continuous, and this will sample really the whole track. Yep, and you'll get the peak velocities. So this is where, like for aortic valve, you'd be doing this, right? Because you want to find the highest velocity to get the best estimation of the severity of the stenosis. Whereas pulsed wave, it's sending out pulses, and it's based on where you're trying to interrogate. It's going to get you an idea of the speed at that point. So it's really cool. So you can sample along the line, right? And for example, in an LVO2 obstruction, you can start more proximal and sample and see, are you getting acceleration through the LVOT? Same with aortic stenosis, right? Are you getting, what's the speed at the LVOT versus beyond the aortic valve? And then with color, I don't, again, fully understand, but you're going to be sampling Doppler all along the probe face, and then it's going to turn those velocities that come back and apply color to those. So you'll see areas of high velocity versus not. And this is obviously great for looking at valve lesions. All right, so formal echo has a lot more, well, several other views, but I think if we know these 4 views, this is like the money shots. So you can see on this guy, but I brought this ultrasound here to show you as well. My starting view is always peristernal long, okay? And this is the same thing when you go back and look at an echo, that's going to be generally the first shot you see. And it's this nice cross-section view of the LV like this, okay? And the way this goes, the probe dot should be facing up, and think of the LV like a bullet shaped or cone facing this way, and you're going to track along this line, usually like parasternal. Okay, that's why it's called parasternal long. You're slicing it in the long axis, and you're going to have to play around and get between the rib space. I've heard of what's called like the seashell method. It's like you can't find it. You kind of do a slow, concentric circles until you try to find it. Some people, you won't get a good view, and you're really trying to see this nice view where you see the left atrium, mitral valve, ventricle, aortic valve. And when we get at the end, if we get there, this is the view for like impella positioning. Okay, you'll notice you do not see the apex very well. Okay, and the RV, what you're seeing is not the body of the RV. You're seeing like the start of the RV outflow tract. So it's not like in this view, in the apical view, where you see the LV and RV like in a similar shape. So going from the parasternal long, all you do is you flip the probe 90 degrees, and you will get this parasternal short axis view. So now you've just basically you've spun the probe 90 degrees, and now you should get this view where you see essentially like the donut of the LV, and the RV's on its side. And kind of as you get more experience, what we really want is to see the level of the papillary muscle. Okay, so there's the papillary muscles here. We want to see that view. And as you get more experience, you can kind of fan up and down, and you can sample all the way from the apex, papillary view, mitral valve, aortic valve, just by fanning the probe up and down. So those are kind of the two views at the parasternal long axis. Actually, I think I have even better slides. So this is the parasternal long, parasternal short, the apical four chamber. This is like when we're in training and you palpate the apex beat. You guys all had to do that, but it's usually kind of right below the nipple on the anterior axillary line or so. And you're going to stick the probe there and fan kind of up this. And you want to find this nice four-chamber view where the LV's on the right side of your picture, okay? RV's on the right, sorry, on your left, and then you see the atria on the bottom. So this kind of gives you like a nice view of global contractility. The problem is a lot of people getting this view can be tough, and we'll get to some of the limitations in echo. Dot is trying to blank.
3 o'clock.
This way. Yeah. 3 o'clock. Yeah. Because the LV is going to be on this side. So you just go like this, and then you pan this way.
About 3 o'clock.
So this kind of starts in line, parasternal long, and then you just rotate 90 degrees. So long, short. Parasternal. Oh, sorry, apical. Yeah, like that. Yeah.
Short is like this angle. This is this angle.
Yeah, and looking more. Think of again the LV. You're trying to get it from like the bottom here. So before short axis view, we were kind of getting it like this. So now heart's like this. We're like looking at it from the apex, hence the name apical four chamber. Sometimes too, you'll see they call it the apical five chamber, where if it's fanned out a little more even this way anteriorly, you'll see the aortic valve come into view, and that's where like Mercedes-Benz sign, right? For it, hopefully. Huh? On the five chamber?
No, not the Mercedes-Benz sign, but you will see the aortic valve and that.
Okay.
Yeah, great.
That's why we have a cardiologist here. If all those views fail, and especially in like a code when the thorax is occupied, doing the subxiphoid view is awesome, right? So money shot. You can see tamponade, you can see LVRV. It's a IVC. It's a great view.
The synthesis at the time of code. We've had like 3 of them,
Yeah.
right?
This.
This is it, right?
This is also partly why we're trying to implement this,
I
right?
did it with that lady over there in 30. Let's do the completely different like apical.
Yeah.
And I was like, I've never learned this one.
Yeah, I've actually done this
This is
under
the code.
ultrasound. Yeah, it's just,
Thing.
yeah.
Go to the left side.
And just follow the parallel to the
Yeah.
scope towards
I-
left clavicle.
So again, subxiphoid, you're going to be underneath the xiphoid. Your orientation's up and down, and usually a little more to the patient's right, because that's where your liver and IVC will be. And then, sorry, that's this one. Sorry, I'm mixing them up. Subxiphoid long axis is going to be under the xiphoid and really push down. Because think, you got to get a view of the heart. So it's like push down and like you're trying to like almost look up. It's
A flashlight.
And it's very hard in the uncomfortable patient like this, the guy who ended up on ECMO. Like he's in distress, and trying to get this view while he's awake was like impossible. Or in the sometimes too with CPR, but during a break, like a quick CPR pause, you could take a look. And then, sorry, subxiphoid IVC view, which is what I was talking about, is when you're trying to see the IVC. You want to ideally see IVC, hepatic vein draining here, and then the right atrium. Okay. This is kind of more for your reference, but as you get more into this, you can start kind of predicting, like, some guy's having chest pain, he's diaphoretic, you throw the probe on, you like see, oh, the inferior lateral wall is down, right? So again, on this view, infralateral, interoceptal. This will be this is on the short axis, personal short axis. This will be septal, anterior, lateral, inferior, apical forechamber. This will be infroseptal, anterolateral. Again, more next level as you get more comfortable with this. So there's many ways, like starting step one of just what's the patient's EF. There's many ways to measure it formally. It used to start with like M mode, and you would measure the change over systole and diastole. It's also what's called the Simpson method, where they this is the one where they trace it, right, and then it's like the cones or the discs.
Method of discs.
Method of
So
discs. Yeah.
Discs on top of each other.
Integrates
it's like a cone.
Yeah.
It's like a cone.
Yeah.
And so you stack discs, and then you calculate the area of the disc, pi r squared, and this disc pi r squared, this disc pi r squared.
Yeah. So when you see them like trace it, you'll see them trace it in systole and diastole, and that's what they're doing. Then there's just the eyeball method, which is really what we're going to use. Okay, which is it hyperdynamic, normal, low, or very low? Okay, and you could maybe even just say high, normal, low would be enough too. So with that, I want to show you guys a couple pictures. So features of hypovolemia, you're going to see a collapsing IVC, potentially hyperdynamic LV, kissing papillary muscle sign. But again, this doesn't always mean you're dry, right? You can see a lot of these things with, like, for example, tension pneumo with a massive PE. We'll talk about how the RV would look, but that's just telling you that the LV is underfilled, okay? Oh, I do have some good pictures here. Okay, so this is the kissing papillary muscle sign. The whole cavity is like obliterating. This is
as we can see in this video, you will see the obliteration of the left ventricle, and the two papillary muscles will touch themselves.
In there, it hurts.
All right, so we talked a bit about LV. The RV, again, there's lots of different ways it can be measured in terms of dysfunction, but grossly, it should be less than 2/3 of the LV on the apical view, right? So you have your LV here, and it should not be the same size. It definitely shouldn't be bigger, okay? We also will talk about a D-shaped septum as there's pressure volume overload. I don't know if I have a good picture of that. Here we go. So this is the peristernal short. See how this is a D-shaped septum? Right, it looks like the donut has turned into a D, okay? And that's the idea, is that the RV now is getting more and more under pressure, so the wall is getting pushed. It can't fully relax and get that nice round shape. Now, to me, pressure and volume are always related, but traditionally it's taught that if it's happening in diastole, it's a volume overload, but if it's happening in systole, it's pressure overload. But they're basically,
So the way I remember that, I haven't been on for that. Pressure and systole, volume and diastole. PS, I think.
Okay. Sounds good. So here you can see, right, LV should always be on the left. And if you have a hard time telling which one it is because they're both massive, the LV should be the much more muscular, beefy wall, right? And then the RV here is clearly very dilated, much bigger. I've seen it over twice the size. Okay. Now, some other numbers you might have in the back of your head. One is called TAPSE. It's the tricuspid annulus excursion, basically. So what they do is they put M mode onto the tricuspid valve here, and they see how much it excurdes or moves during systole, right? So the idea being, if the ventricle is contracting nicely, it'll
only on 410 work.
Yeah,
Yes.
yeah. Okay. This will move up and down. Okay. Again, this is kind of crude, but it's one of the measurements. And so they'll measure this. So if this number is high, like 18, your RV is probably excurting pretty well. It'll also generally correlate with what you're seeing. Like, it generally isn't a huge surprise. And then S prime is kind of another one where they're measuring the tissue velocity of that valve.
Yeah. Normal PFI, Pepsi strolling along at 14.
The problem is the accuracy of measurement too can be huge, right? Are you getting it? Remember when we talked about having things on axis, right? So if it's not moving in this line exactly, you know, this angle, the more this angle becomes off, the more the measurement is off, and then things are sometimes out of plane. Like, that's why these things always have to be put into context. Yeah. If you see signs of severe RV failure, but there's like no TR and like no pulmonary hypertension, and you know, you gotta put it all together. It's kind of my perspective. Speaking of which, the other number you'll often see on the echo report is the RVSP, or which is kind of indicator of pulmonary hypertension, right ventricular systolic pressure. To measure this, you have to have a TR jet, and the reason is, what gets to this simplified Bernoulli equation, where pressure can be estimated by the maximum speed squared times 4. I don't remember the basics of how they came up with that, but all right, this calculation is kind of one of the cornerstones for, you know, correlating pressure and velocity in an echo. So if you think about it, what is the pressure in the RV going to be? You have to be able to overcome the CVP, right, to push blood backwards, because you got to fight against the CVP. And then you're also going to have the component of how fast blood is moving out. So what they'll do is they get a TR jet and they find the peak, right? So this is minus 4 meters per second. So 4 squared would be 16 times 4, 64. Then you add the CVP. So that's why here they're getting, it's saying automatically, the max velocity 419 centimeters, max peak gradient 70 millimeters of mercury.
Centimeters converted to meters per second is 0.1. So
yeah.
4.19 squared.
So that's just, again, you don't have to necessarily dig so much into this. It's just to tell you that to get a measurement of pulmonary hypertension, you need to have a TR jet. Faster the blood goes backwards means that the pulmonary pressures are higher. Sorry, the RV pressures are higher. In general, the RVSP should equal the pulmonary artery systolic pressure, unless you have somebody like we had in bed 22 or 23 for the last a couple of months ago, where he had pulmonic stenosis, which is pretty rare, so that there is a gradient across the valve. And normal should be less than 40. That's why in a lot of our patients with COPD, they have severe pulmonary hypertension. This number hits 60. Okay. Now, the IVC, I feel we all use it and pretend it's great when it fits what we already believe. Let me just put it that way. So in general, it is not a good indicator of volume status, volume responsiveness, or the CVP. The correlation ranges from 0.27 to 0.76. All of this is pretty poor. And the problem is there's so many variables that affect it that even studying it between people, you can't really, you just can't compare. For example, if somebody is breathing really hard, the IVC will collapse unless the pressure is super high. On the other hand, if you're on a positive pressure ventilation, they actually still might be dry, but because your PEEP on the vent is like 12 or 14, the IVC might not collapse with or vary much with the vent settings. The other thing is it's dependent on what's the pressure in the chest, what's the pressure in the abdomen, right? So a guy with abdominal compartment syndrome and a abdominal pressure of 25, you know, the IVC might be tiny, but no matter how much volume you give them, it doesn't matter. Like it doesn't tell you what the CVP actually is. The other part is measuring it. So you'll see a lot of echoes where they'll measure it, and you know, as you breathe, it will move not only up and down, but side to side. So measuring that exact distance is a bit of a fool's errand. Regardless, you typically measure it 2 centimeters from the right atrium. I feel that's useful in extremes, and like the CVP needs context, and I would never really just only rely on that. If you see somebody with a low EF, diffuse B lines, and they look like they're in cardiogenic shock, but they're breathing like crazy and their IVC is collapsing a little bit, I don't think they need more fluid. Like that's kind of my approach. Again, despite that, this is the dogma that exists in Echoland, where they will take your IVC, how much it collapses, and spit out a right atrial pressure. This was developed in like healthy volunteers, okay? But this is what is used in all echo readings, essentially, is my understanding. And that part of it is they do, did they change a little bit? They do need a number to be able to predict that RVSP, if you remember, because you need an estimation of the CVP, and then you need that pressure in the RV. So they do need a CVP number to estimate that. And so this is really where this comes from. Like Dan is saying, it has changed a little. Is the number higher for IVC? 2.2, yeah. 2.2,
okay. And then for echo reporting purposes, they say those are the pressure, and then you have to give a number. So pick what's in the middle. So you say 3, 8, and 15.
It is a bit of pseudoscience, but it as a component of the RVSP, it generally doesn't contribute. It's not like the game changer of what that number will be. Tamponade, this is probably what everybody wants to be good at and not miss. As we mentioned, this is best seen on the subxiphoid view. Couple things. Tamponade is a clinical diagnosis. At least that's what the textbooks say. Echo does not diagnose it, but it provides supporting evidence to what you think. And important thing here, for example, if you have a slow effusion, for example, like a cancerous or inflammatory effusion, it can get a lot bigger before it causes clinical tamponade. And the reason is you've had time for the pericardium to stretch and all that, everything to kind of equilibrate. Versus if you have a sudden bleed, or it doesn't take much, the volume can be much lower. Not even to get into regional tamponade, which is like a whole different beast, and we're mostly in like the cardiac ICU. That being said, some of the findings you should see, the IVC essentially should be very dilated and not varying with respiration. If you see a effusion and you see a collapsing IVC, it's probably not tamponade. That's at least the teaching I was taught. Then getting further on,
it is pretty much the linchpin.
Yes. Yeah. If there is, then the first thing you would start seeing is late diastolic collapse of the right atrium. And then the later finding would be early diastolic collapse of the RV. And those phases are really when the pressure in that chamber is the lowest. What you'll often see of how on an echo will read is they'll either say they see one of these two things, or they'll put Doppler through the tricuspid valve and see how much the flows vary with inspiration. And if you guys remember from like clinical exams and stuff, you would measure a pulsus paradoxus, right? So you'd measure the pressure as the patient's breathing, and you look for, as you release the cough, kind of when you hear one sound and then when you hear both sounds with inspiration. So this is essentially the same thing as a pulsus, but the echo version, right? So as someone would take a breath in, there's more blood getting into the RV, overcoming essentially the tamponade physiology a little bit. And so that's why you'll get these big swings in the pulse. So again, all these things will lead to features suggestive of tamponade. And sometimes they'll say like early tamponade, but again, it's a clinical diagnosis. So that being said, it looks like a pretty normal, very minimal effusion here, right? This is like trace. This is not generally causing anything. This is getting a little bigger. This looks like there's some kind of collapse in the right ventricle, but again, this isn't really the best view, right? IVC looks dilated here. This is honestly also kind of a bit beyond our level of what we're going for, like trying to time it with diastole and see what's exactly happening. But
can you click on, is this an active link? Click on tamponade M.
Oh, okay.
Yeah, so what they do is they move the G tracing. You can see it in green there. Can you see it? So this right here is the EKG tracing. You can't really see on here for whatever reason, but like you can see where systole is with the QRS. So you know that the right ventricle, which is this waveform here, is the right ventricle. This is the waveform we're looking at. It should come in during systole, right? And then it goes out during diastole. This is the right ventricular free wall. You're sending an M mode right down through here. And the first structure you see is the right ventricular free wall. That's this waveform tracing here over times on the x-axis. All right. And then so during systole, after the QRS, the free wall comes in and then it should go back out, but it shouldn't have this dip, which is during diastole. So that's showing.
All right. That's all right. No, that's good. This is kind of showing that variation in respiration. You'll see they'll take the Doppler tracing and run it out much longer. Okay, so you'll measure the peaks between these two. Yeah, these are all pretty bad here. One thing I did want to show from our perspective is when is it pleural and when is it pericardial? Because sometimes you'll put the probe on and you'll be like, oh my gosh, this is this huge effusion. The aorta is the key. So if the effusion comes in front of the aorta, it's pericardial. So this is a small pericardial effusion and behind is pleural, okay? That kind of also fits, right? You don't see the RV collapsing up here. They're also, they will measure the size, the maximum size too, and that can correlate. That's how they would say like small, medium, large. I don't really get it. I think large is what, above 2 centimeters. That's, but again, if it's happening rapidly, it could be tamponade and not be technically large. This is kind of getting a little more in the weeds, but we've had a few of these patients, which is kind of what triggered this talk, and it's being able to identify LVOT obstruction. Now, this is classically seen with HOCM, where the hypertrophic obstructive cardiomyopathy, where people have a really thick LV, and when they get dry or they get tachycardic, the LV contracts so hard that it essentially drags, it sucks the anterior mitral leaflet into the LV outflow tract, causing it's essentially obstructing itself. And that can be a contributor to shock, right? And there's things we can do clinically, which I'll get a ton into, but potentially beta blocking, fluids, if they're agitated or if they're in fib, like treating the underlying cause to get at that. And this is kind of but you can see the cavity's tiny and that the mitral valve is getting sucked into the LV outflow.
The biggest case of SAM I've ever seen.
And when I was talking about Doppler and how with pulse wave Doppler you can sample like at different points. So here they're trying to look at the LV outflow tract. Bottom line with this is you get this like dagger shaped Doppler tracing where it's kind of late peaking and very sharp and pointy because the flow is accelerated. And you can get this not just with SAM, or with HOCM. There's other ways you get this, and it's not always from the mitral valve. I think the case we had was it was happening like in the papillary muscles, it's originating from there. Okay, another quick point: bubble study. Why we do this, what it looks like. So the case Dana and I had recently was super cool, where the guy had refractory hypoxemia, and as he was putting in the CVAD, I said, shoot some like saline and let's do like a kind of mini bubble study and see what happens. And it was like super positive. So the way a bubble study works is they're injecting agitated saline, which should go on the right side. You shouldn't really see any bubbles show up on the left side. If you see them within 3 beats historically, that's suggesting there's a hole in the heart somewhere. That could be ASD, could be VSD. I'm sure there's other things. If you do see bubbles, but it takes longer than 3 beats, then it's probably a shunt somewhere else. The classic one would be like you have an AVM in the lungs, and that can sometimes be triggered by like end-stage cirrhosis, hepatic pulmonary syndrome. I've only seen it like once or twice. But so here, this is all full of the contrast, and boom, right within a few beats, it just lights up. So super cool. And like, you know, I've done these a few times in like a semi-emergent setting, and it's pretty cool to see. I thought I had some. Yeah, there's some stuff. I guess this slide is in here. Limitations of transthoracic echo. If you see the report, and again, this is the problem when I feel there's these reports that have a ton of information, and a lot of us don't get good training on looking through the report or understanding the physics or limitations. When you see poor quality study, if your patient is doing poorly, you have to think, do I need to redo the study? Do I need to do a TE? A lot of our patients are very obese, and getting the windows is very difficult. And as you kind of get experience looking at them more, you'll be like, man, I don't know how they could make any judgment off of what we saw, right? Or that's why they said it was a poor quality study. You just can't see anything. Another one would be a lot of our COPDers or patients that are on the vents, they get hyperinflated and the heart gets displaced very inferiorly. So getting those, like, especially the peristernal views, I find can be very difficult. The cardiac surgery patients have a ton of bandages and drains. So getting any views often is very tough. And that's why often we just jump to a TEE, which is amazing. I've learned that when you have really bad eccentric mitral regurg, sometimes you can underestimate it with a transthoracic echo because of shadows, and also because of you just can't get the jet to be in line with your Doppler. So you can really underestimate it. I had a patient with a ruptured path muscle, and they were in horrible shock. The working diagnosis was pneumonia, and turns out, and the echo read like mild MR, and it was like, yeah, it was just wide open flail leaflet. Endocarditis and pacer vegetations, the issue is going to be often when they're much smaller, and seeing like the spatial resolution will be worse. And also the tricuspid valve and the right side you might not see as well on transthoracic echo, which is pretty much why the reflex is to get a TEE on all these people. You can underestimate certain valve gradients. The apex can be poorly visualized, right? Aneurysms, thrombus, infarcts. And the aorta, obviously, you do not get really any good views of the aorta, just a tiny bit of the like aortic root, right? So low threshold to use other tests. This is also for your reference, but the echo can kind of be used to correlate a lot of times with certain things on the SWAN. I already talked about IVC not being great, but RVSP is pretty good at predicting your pulmonary pressures. And this is a cool one. Not to, I can't explain diastology super well, but E prime is basically a number that they're looking at how well the mitral valve, essentially apparatus, is relaxing, and then also at how the mitral inflows are. And that ratio is one of the numbers that they look at for diastolic dysfunction. As that number goes up, it's telling you, or it can tell you that your wedge pressure is going up. Your left atrial pressure is rising. I don't know, Dana, if I've not to get into the weeds. I've read on diastology many times, and it's kind of hard to wrap your head around.
Yeah.
But and for us, we're not talking about patients with diastolic dysfunction. We're talking about someone comes in with some kind of shock, maybe cardiogenic. But anyway, this number, if you see it and it's like 5, they probably don't have a super high wedge pressure. If it's 20, they probably do, right? So it's kind of good on the extremes. And that leads to one of my favorite echo findings in the critically ill, which is this LVOT VTI. Now, it sounds like a lot, and I'm just going to give you a quick primer on it. This is basically a number that as you put a Doppler down the LVOT, you'll get this waveform, okay? And it's sampling the velocities of the blood as it moves through, like, out of the heart, right? So using a bit of math, remember from like 12th grade calc or whatever, you're trying to imagine a cylinder of blood moving through that valve over time. So the machine itself, when you trace this, will give you what's called the VTI, or velocity time integral. It's kind of like with calculus, where it's integrating all the velocities over time, and velocity times time gives you a distance. Okay, so it's going to be in centimeters. So that's going to be the height of your column, and the diameter is going to be pi r squared, or sorry, the base of the cylinder is going to be pi r squared, where r is the radius of your aortic valve opening. Now you can kind of get into this and trying to calculate, okay, and I remember a cardiology fellow doing this. He like measured the LVOT, he did the pi r squared, he multiplied it by the VTI, then he multiplied by the heart rate, and you can estimate the cardiac output. The lazier version is you can just straight up look at this number they give you. If it's low, less than 15, you're looking at a low stroke volume. That doesn't necessarily mean low output, because if their heart rate's 130, 140, you know, it could still be fine. If it's high, it's generally reassuring. You're pushing out a lot of blood through the aortic valve. So it's probably not a stroke volume problem. That's kind of my bit on that. But this is, again, just like when you look at an echo report, you know, someone comes in really sick, they did an echo in the morning. These numbers are all in there. And so it's kind of cool to just say, hey, I know what these are. And this looks high, this looks low, and go from there.
If you look, a lot of times though, I can put SV on like in the calculation,
yeah,
like in there,
yeah,
say SV short.
Yeah.
But you have to have the LVOT.
I put some slides on valve disease. Again, I don't want to get too much in the weeds on this. I think for the ICU intensivist group, it's really, we're just looking at the like severest of severe. So if someone comes in, they're super shocky, the aortic valve looks maybe a little thick and chunky, you can actually put a Doppler through the valve and trace it. And if you're getting, the machine will tell you what the peak gradient is, and it'll integrate and average this and give you the mean gradient. Okay, so mean gradient of 40 or peak velocity of 4 is consistent with severe aortic stenosis. Problem is the velocity measurements really depend on A, the angle and accuracy, and B, how well the LV is pumping, right? If you can't pump well, you're not going to get an accurate pressure, even if the valve is shitty. So and that's the low flow, low gradient patients we see. But anyway, these numbers, when you see these, this is usually, they're really trying to get this mean gradient of 40. And sometimes you'll see, you know, mean gradient was 30, but the EF's low. Let's try a debutamine stress test and see if we can mimic getting that number higher. On the other end, severe AI, which is rarely, I mean, in the MICU, rarely encountered as their primary problem, to be honest. I guess the only time you would see this would be like a dissection, maybe, like a type A dissection with severe AI, although you would hopefully know about that sooner. But some features would be, you'd see a dilated LV, a wide, dense regurgitant jet through the aortic valve. And this number, the pressure half time, so they're, again, sampling blood through the aortic valve. This is coming backwards. The faster this slope goes down is the pressure half time. It's basically what's the time that it takes the pressure to get cut in half. If the valve's wide open, there's like the gradient between the two goes down, right? Because there's a bigger hole and the blood just rushes back much faster. So the number to remember here is 200 milliseconds or less. So this patient, pressure half time over 590, this is like very mild, right? One of the other features you might see is if there's diastolic flow reversal in the aorta, that's a feature of severe AI. And you might, I've actually seen this a few times on the cath lab images as they inject the dye. You will see like the blood moving back like dramatically. The other way you could see it is on an ultrasound or a TE, would be the classic way to see it. Severe MR, I'm not in the business of trying to quantify it, but again, you can take color and put it across any valve. It's pretty easy. And area and how much that nutrient fills up. Again, with all valve diseases, acute and severe is much worse than slowly developing valve disease. Yeah. So if this happens suddenly, again, like the patient I had, she was fine, she started coughing, to the valve, suddenly this is wide open, it's through the roof, flash pulmonary edema. You know, that patient handles it much worse than somebody who's got severe LV dysfunction. That patient's had time to remodel and acclimatize. The last slide, I guess, the last slide was just for your reference as well on impella position. I know you guys already do a lot of work with impellas, but this is a good thing to practice. This is for the CP, if you remember. So if only these was actually the picture it looks like. This is like a diagram. So this is more what it looks like if even, right? So what we're trying to do is we want to see two things. We want to see the aortic valve. We want to see the dropout, which is the inlet here on the pigtail, right? So this is going to be sitting deeper in to prevent it from sucking into the LV wall. But here you should see a gap. So you think of like a straw, and then there should be a hole in it, essentially, like kind of a few centimeters from the end. So ideally, you measure from here to, you know, this is where like it's a bit of an art, I feel. You just move the tracer a little bit, and you'll be a centimeter different, but you want it to be at least or around 3.5 centimeters. So that's kind of what I had.